Thank you. This is, I'm not very often at a loss for words, but I think it's because I'm still taken aback by the fact that I'm here. I was telling Jeff that, wait a minute, I don't care how many degrees I have, I can never tackle technology. Okay, so no, I really am really humbled to be here. It is amazing to think of how much impact we can have when we follow our passions and when we do what we know in our heart is right. And I think, from a public health perspective, we are not here following this cause so that we can all ride off into the sunset with our millions. Our riches will be coming in another lifetime. It's because at the heart of what we do is what we know is right. At the heart of public health is social justice. And so to have moved from television news, which was my first career, to public health, it was because when we think about having impact, it's not about a headline, it's about impacting generations, the ones that we see today and the ones ahead of us. And so I was telling Jeff that it didn't really hit me until today, like how all the strings have followed me and how building community resilience really was born at, so the South Campus Center has been elevated to the lake house. That's how others hear me talk about this. But really sitting there at the South Campus Center, looking out at the beautiful cut and watching the debates over the ACA and knowing that it wasn't about changing healthcare, that what we were doing is we were socializing the language of public health through that legislation. And regardless of what happens with that legislation, we have changed the thinking around social determinants and around community health and understanding that healthcare is but a wee little piece of that. And so that was really how my thinking around adverse childhood experiences and using that as the basis for a movement of public health was born, by sitting there in that lake house and really listening to Senator Baucus and others debate the merits of this legislation. Because I didn't see the legislation as much as the opportunity, but the opportunity to change the conversation in our communities. And so that's what I've been doing since I left the lake house in 2011, is building this resilience movement. And I have been, I think me more than anybody, have been really taken aback by just how far this work has gone and how quickly. And so looking at how do we build community resilience, and I do want to be really clear that when we talk about resilience in this work, we're not talking about how we help individuals bounce back, because if you understand equity, we know that if we're only helping individuals and communities bounce back from what we already recognize are an equitable starting point, then we're a part of the problem. That resilience is so much more about helping not only individuals bounce back from the chronic adversity that is going on in community, but it's addressing that chronic adversity to begin with. And that's what public health is about. We're about prevention writ large. And so really community resilience is about not only helping individuals and healing individuals from that impact that they receive in community, but it's doing something to mitigate that and prevent the impact, so that we're putting supports and buffers in place so that communities can bounce forward. So that's my introduction. And that's also I've been lobbying for Merriam-Webster to also change the definition of resilience. So there's my, anyway, we'll see. So building community resilience, the process is a paper that I had published in 2017. It was supposed to be my dissertation. That's a whole nother story. But that's what happens when you use, and how many of you are students in this room? One of the best pieces of advice that Colleen Hebner gave me, who is the chair of the MCH program, is use every one of your class assignments to advance your research. So my poor doctoral cohort heard so many presentations about building community resilience. And one of my first papers that I wrote was actually taking these questions that I had from the research that I started here at the MCH program of, if we know so much about the science of ACEs and that the impact of ACEs across the lifespan are not only connected to chronic disease, but those chronic diseases are also the underlying factors of the leading causes of death in this country, then why the hell aren't we doing more? That was the essential question that I had for pediatricians, for social workers, for educators, for first responders. If we know better, why aren't we doing better? And through those key informant interviews, I found that the greatest barrier was how? How do I take the science and the research and actually change practice and program? How do I use that science to inform policy? And I said, well, if it's just a matter of you don't know how, then we're going to build the pathway. And that was the simplicity of building community resilience, a process, providing a roadmap, a way, a systematic way for us to go through and collaborate across sectors to really address those root causes of adversity in our communities. Understanding that it was not going to be driven by healthcare, that it's not driven by public health, but we certainly have a role in pulling, and an opportunity in pulling all of those sectors together. So when we talk about creating shared understanding, we can't solve it if we don't understand it. Fundamental to that was thinking about, when we talk about ACEs in our communities, what are we talking about? When we talk about inequity in our community, what does that look like? And what does the community say that looks like? Not just using our public health data, which we love. We love our data. But the community also has data. And the community also has wisdom. And why aren't we leveraging that alongside all of our letters and all of our training? But when we go through, once we've established that shared understanding, then that comes time to figuring out, so if we know the problem that we're trying to solve, what can we bring to bear? What are the resources that are available? So again, this is very much a strengths-based approach. This recognizes that there are deficits, but it also recognizes that if we only look at what we are bringing to the table and not considering what public education brings to the table, what law enforcement, public housing, economic development, all of these other resources that are in community, then we're not going to get anywhere. And that's what we've been doing. We've been going down our silos, whether it's just going after obesity or whether it's going after smoking, and not thinking about the entire panorama that is impacting our communities. Nor are we thinking about all of those resources that can be brought to bear to solve this issue. And so going through this, I realized we had to fundamentally think about how we use our resources and how we also connect across sectors to impact change. And so understanding that once we figure out what we have to bear, that helps us to understand who should be at the table. But when we also see what we don't have, that also means they need to be at the table too. And how do we bring these sectors together? And most importantly, how are we doing all of this that is community-informed, community-driven? And so that's the hardest part of the work that we've been doing over the last 5 years, is actually not just working across sectors, but that authentic community engagement piece. As our partners in Cincinnati like to say, you just have to say yes to the mess. It's long, it's hard. You take 2 steps forward, you take a step back, but you stay in it. So that's BCR, Public Health 101. But that's the process. And this is the movement. This is the part that really humbles me, to be able to sit here at UW where all of this stuff started forming in my head, and to recognize that in 2020, not only are we doing this across the country, but I've been able to bring the work back here to Washington State. And what was most significant about bringing the work back to Washington State is not only are we working in community, but the work is being funded by the Department of Social and Human Services. I'm sorry, I don't know how better, I got more letters that I could come up with, but that's freaking incredible. Because what that really says is when we're talking about systems change and we have systems that are invested in that change, we are making a difference. We can make a difference. And so they are using, DSHS is using BCR as one of those strategies under Governor Inslee's overall campaign around poverty, his anti-poverty initiative. We're embedded here in King County, Pierce County, Yakima, and Whatcom, working with community partners that are looking at what is the adversity, what is holding back families here in these counties around poverty. What can we do? What are the partners that can be brought to that movement? How do we make that systems, that long-term change? And the DSHS vision is, these are just 4 pilot communities. They want to create a resilience movement statewide and spread that from the entire state throughout all of the counties. That is truly humbling for me. But it's also, I think, an opportunity for us to really think about what is our role in public health as chief health strategists. And that's the next chapter of this work. So you'll see that there are also a number of public health departments that the badges there: Cambridge, Massachusetts, Dallas County, Texas, Mesa County, Colorado. We have Louisville, Kentucky, and Appalachian District, North Carolina. That's the latest chapter of this work. That was my dissertation, was creating a framework for community resilience, taking it from something that's theoretical to something that's measurable, using dynamic systems modeling so that we can quantitatively begin to isolate policies that are driving inequities in our communities, and then how that's connected to population health. So that's the project that's been funded by CDC and NACCHO that we are doing with public health departments using the BCR process, but this new community resilience framework. But again, the problem that we're trying to solve. One of the things that I learned, and I'm so glad to see Dave Gombrowski here, thank you, and from one of his classes is, how important how we translate all of this theory of public health into something that people understand. And so when I started doing the work around ACEs, it was, did people understand the science of ACEs? Do they know what they look like? And do they understand the interconnectedness between what's happening to individuals and that community environment? So I spent a day at my computer thinking, I got to visualize this. I got to make it simple. Keep it simple, stupid. Trees. Everybody knows what a tree is, right? So let's make a story around the trees. So adverse childhood experiences are those branches and those leaves, those things that we can see. So if you're an educator and you have a child that's agitated, that can't sit still, you get something's not right with this kid, right? Or if you're a pediatrician and you're with a new mom, and it's a well check, the first well check, and she's not doing eye contact with the child, and she's just something's not correct here. You might suspect maternal depression. But what you don't readily see is, what is on that mom's mind? Is she thinking, I'm going to have to move back in with my parents because I can't afford the rent, I have to make some really tough decisions. You're telling me that it's okay if I don't breastfeed so I can go back to work, but then that means that I have to pay for formula that's super expensive. I'm going to have to make some choices about that, as well as about affordable childcare. You don't see all these other contextuals that are going on. Or the child that can't sit still. Is it because there was a shooting in their neighborhood last week or yesterday, and they have to walk past the memorial every day, and they have to wonder, is it going to happen to me? Is it going to happen to my friend? We don't know what's in the soil. And so if we just want to attack the leaves and the branches on that tree without thinking about what's driving adversity in that community, then we're not going to solve the problem. And so that's what I was trying to do in creating a framing for people to not only fully see the problem that we're trying to solve, but also for other sectors to see their role and their contribution to creating a much more healthy, rich, nutrient-rich soil for our communities. But also helping people to see that if we're only looking at the ACEs, we're only looking at outcomes. You're not looking at the drivers. And the drivers are in the policy and in the practice piece of this. So a simple graphic, but it says so much. And we've been using this across the country. In fact, a lot of our workshops, we give them a blank tree. Tell us, what is the story of adversity in your community? And what are the drivers? What's in your soil? So another way that we've learned how to use our public health data to tell the story, because one of the things that I learned here is that data can be powerful, but one of the other things that I learned that we don't learn in the classroom is that data alone is not enough to affect change. There's no data without stories and no stories without data. That's one of our principal rules in BCR. And so we created these infographics that we've actually put out on our website. They're free. Download it. You put your data in there. You tell your story of your community. But this is one that we created for our partners here in King County to help them not only think about what are the drivers, what do the pair of ACEs look like, but how would you tell that story? So one of the pinpoints that we use is economic hardship, and economic hardship rather than poverty, because economic hardship is really what more of our families are going through. That poverty level is an artificial level. We know that you can be well above the poverty level but still experience economic hardship, and economic hardship in itself can be an adverse childhood experience. But what does that look like? Tell me the story around 1 in 5 children in this county experiencing economic hardship. Does that mean that their family is paying more than 1/3 of their income on housing? Does that mean that they are accessing food pantries to keep food on the table? There are a lot of different indicators here that we can use to describe economic hardship. And those are important because it helps other sectors to see what is their contribution to alleviating economic hardship. So that's how we got to the equity conversation. That's how a group of bandits across the country moved from talking about adverse childhood experiences to putting equity at the center of our work, because we realized that if we were trying to create resilient communities, if you're not addressing equity, go home, because you're not doing anyone any favors. When we recognize that equity or inequity has been the #1 driver of trauma in our communities, then you are not authentically engaged with community if you're not addressing that issue. So to paraphrase my favorite shero, Tina Turner, that's what equity has to do with it. So along the way of writing a public health dissertation, I had to dig deep into our country's history to really help to, as my grandfather, the attorney, would say, bury them with evidence. To help them understand, help our partners, and even help us in public health understand how systematically we designed a system in policy to drive the inequities that we see. These are not merely about people making bad decisions. These are about the systems and the environments that we created. And so I would love to go through this timeline, but I only have 20 minutes. But you get the idea that each of these policies have actually built upon inequity. So if we want to change the trajectory, we have to rewrite our policies in order to rewrite our systems. And just to give you an idea of what that looks like, so in the New Deal, one of our largest economic investment initiatives that we had in the 20th century, baked in the New Deal was inequity. That African Americans could not access that ability to own a home. So that when you look at, and this is using the data again, when we look at the disparity in household wealth by race, and families of color on average have $18,000 in accumulated wealth, and white families have $171,000 in accumulated wealth. And we know that the number one way of Americans passing on generational wealth is through household ownership. And yet you had by the way that we decided to back mortgages in this country, effectively you locked out people of color from obtaining their pathway to generational wealth. And yet you will hear some people say, well, those are poor decisions. We just need to teach them financial literacy. Anywho, so one of the things that I do recall in my MPH classes here was hot spotting. But I want to push us a little bit further when we think about how we use these public health data to look at equity. Not just looking at chronic disease, but mapping that also with how chronic disease and chronic inequity, social inequity, they are co-located. And this right here helps us to understand. This is the King County, and if you remember the map earlier, it showed where we had areas of redlining. Historically, 60, 70 years later, we still have the remnants of those effects. Where you have concentrated poverty, you also have concentrated chronic disease. No, it's not merely just because of the choices that individuals make. You have to accept that it's because how we deliberately designed our communities for these outcomes. And so that's how we use the data to help tell the story of what we have created are these vicious cycles. So the framework that I created around community resilience is looking at three major sectors and their contribution to both the outcomes that we see today, but the opportunities to right that. So all of the public health literature it's been well established the connection between housing, stable housing and health outcomes, education as a marker for health outcomes, as well as involvement in criminal justice. And so also understanding from looking at a lot of ethnographic studies around community tone and makeup, that we know that those three sectors also very much inform that. And so if we're truly trying to change a community's characteristics, these three sectors have to be at the table. But as public health, using Public Health 3.0, that chief health strategist, that's our sweet spot of bringing all of those partners to the table. So this is just another one of those ways that we use these data, these public health data, to help these other sectors begin to understand their role. So for housing, it's thinking about, what are we going to do in King County to address the affordable housing need? It's not just merely pushing people further and further south. It's really addressing the need where we are. So I'm running out of time, but part of the community resilience project, or the Resilience Catalyst project with the public health departments, is really helping to stress this is what we know about the drivers of generational poverty that also are drivers of cyclical adversity, and that these sectors, as well as these opportunities, the housing, education, economic development, access to care, are truly the pillars of community resilience. And we have plenty of public health data that support this. And yet, we haven't really used these as strategies writ large. And so that's the next chapter of this resilience movement, is actually using public health as that chief health strategist to bring those sectors together and really use a multi-sector, multi-dimensional effort using data and the BCR process when we talk about shared understanding, we're creating a shared understanding around structural racism. Call it what it is. It's okay. Clutch your pearls, fan yourself. We're still here. State of readiness, because it's not about you, and it's not about calling out racist. I'm not calling you a racist because this policy has empowered you inequitably. I'm saying that you have benefited from these policies that have actually held others back, and that we have to address this Because if there's anything that has shown us that these policies are driving negative outcomes for all of us, it's this opioid crisis. And one of the things that I've learned in this conversation around understanding how policy, yes, was written to exclude individuals and hold back individuals of color. But in 2020, if you can't see that what this policy is really directed at one color, and that color is green. So when I go to Edinburgh, Pennsylvania, when I'm in East Texas, when I'm in Arizona and having these conversations around equity and no one in that room looks like me, and yet they're leaning in, it's because they understand they too have been left behind, and what is happening to their community today, the despair and inequity, is also being driven by these same policies. And that's the role of public health. That's our role. That's what Public Health 3.0 looks like. It's helping to reframe the social determinants and really help people understand that when we talk about social determinants, what you're really talking about are systems-driven community characteristics. When we talk about homelessness, we're not talking about people, we're talking about a failure of the housing industry. When we talk about lack of educational attainment, we're not talking about people who can't be taught. We're talking about a failure of our public school system. When we talk about increased juvenile detention rates, we're not talking about bad kids. We're talking about all of these failures of all of these systems. That's what a social determinant really is about. But we've been using the language of social determinant to label people and to program our way out of it without putting the systems that are driving those outcomes to task. Because all of those things that I'm talking about there on the left-hand side, those are performance indicators. Performance indicators of all of those systems. That's what a resilience revolution looks like. And so this is a more virtuous cycle. I showed you the vicious cycle previously. But this is a more virtuous cycle. This is what it looks like when we change policy that supports more equitable practice, what it looks like. And it can be done. It's not outside of our reach. So that is the work of building community resilience, but I would be remiss to say and not talk about the policy aspect of this work. So it's not just about creating a feel-good resilience movement, and we're changing things in our communities, of which we are, and I'd love, if I had another hour, I could talk about all of the things that have happened in all of the communities, but we got a website, and we got videos. We have a YouTube channel. But I think the thing that I'm also very proud of is the fact that we've had substantive policy change that we've been able to influence. And I will close this on one note, because I know you said, Jeff, about being more hopeful for 2020. But even in this crazy period that we've had over the last 4 years, we've had policy wins. One of the ones that's most recent is, how many people here have heard of Senator Blunt from Missouri? He's not exactly a raving lib. And Missouri is certainly not known for its public health, initiatives and support. But we trained up a group of advocates from St. Louis and from Kansas City, and we had them go in and talk about what community adversity looks like in his office. And the reason why we targeted Senator Blunt is because he sits on the Appropriations Committee for HHS. Yeah. Right? I learned a few things along the way to get an MPH. And one of the things, purse strings matter, right? And so one of the things that we are trying to socialize, even in this government, or this administration, is equity. And so we started talking about the differential outcomes in maternal births and infant deaths, infant mortality. And we use data from across the wide state of Missouri. So, in depressed counties that have been hit hard by all HHS departments or agencies that were going to, that were using a date or reporting out on data around infant mortality and birth outcomes, were expressly being told that they needed to also look at the effects that the difference in outcomes for women of color, African American women specifically, as well as their infant mortality, and the association to racism. And I said, well, slide it in there. Let's see if we can, maybe they won't notice it. Like you wrap up the medicine for your dog in peanut butter and hopefully it goes down. So we kind of sandwiched it in there. Do you know he took it word for word? You can look it up, it's there. But that's one of the things that I don't want this work to be positioned that this is a Democratic issue, this is a partisan issue. This is an American issue. As I said there on that framing there, the earlier, that this is an American public health issue. We are all in. And so I don't just come to Seattle. As I said, I've been in Edinburgh, Pennsylvania, where I had to drive past a KKK flag and a Trump-Pence flag, and yet they asked me to have a courageous conversation on race. It is possible. And no, I have no scars to show for it. I did need a security detail. We can do this. We can do this by connecting into our humanity. We can do this because it's the right thing to do. And more importantly, in public health, we are taught to meet people where they are. So I will go wherever this work takes me because I think that is the call, that is the duty, that is the charge of all of us in public health. So my last statement here is, number one, if your butt's not on fire after this talk, you might want to check your pulse. But we can do this. We got this. This is the call for Public Health 3.0. This is the call for the next generation. This is the call for us as instructors, as leaders, to put this into the veins of our next generation. Because I'm not going to see the benefit of all this work in my lifetime. As that timeline shows you, we got over 400 years of policy to undo. But we start now. We can do this. So in closing, I just really want to thank UW for taking this wild woman's idea back in 2007 when I was accepted into the program, by supporting me with the GoMap tuition grant. Made a difference. It made a huge difference because my 20-year-old daughter who's here tonight was in grade school, in private school. We had a lot going on. I really want to thank some of the faculty who's here tonight, Dave Gombrowski, Bud Nicola, Colleen Hebner, Aaron Katz. I know he's not here tonight, but woohoo. It was a special time. And for those of you who are students here, this is the most special time of your career. You really can take everything that you're learning in the classroom, the theory, and turn it into action. Translate all of this rich research that we generate here at UW, but also in the public health field writ large, and turn it into action. Because together, we can build a resilient nation. So thank you.